Hi, everybody. My name is Woo-Jin Kim. I'm a neurologist and also palliative care physician here in Ottawa, and also one of the 5 physicians who are involved in neuropalliative care practice, and then including Dr. Watt here. I'll hand it over to her.
Okay. Hi, everybody. I'm Dr. Christine Watt, also a palliative care physician here in Ottawa, and very excited to have the chance to talk to you today. So I think we will go ahead and just dive right in. Perfect. Okay, so this is kind of the usual things, the usual conflict of interest slides you may have seen before. Between Woo-Jin and myself, we'll just mention that we do get research support from both the Ottawa Hospital and Briere academic medical organizations. We do some work with the ALS Society of Canada and Brain Canada as well. But we have no other financial conflicts of interest to declare. This is kind of one of those standard slides that talks about mitigating potential bias that you've seen before. And as is often the case with palliative care, we will be discussing some of our medications that will be off-label today. Okay, so we're going to talk about a few different things related to Parkinson's and related disorders today. First, we're going to talk about what those things are. What is Parkinson's disease and Parkinson's related disorders. We're going to talk about the trajectory and signs of disease progression. We're going to talk about the palliative care needs of patients with Parkinson's and strategies for managing those things. And then at the end, we're going to talk a little bit about the program that Woo-Jin alluded to that both he and I work on, which is the Neuropalliative Care outpatient program that services the Ottawa region. And so I encourage you all as we go through the slides, and we'll have some time for like interaction and some polls, just to kind of keep Mr. J in mind. So Mr. J is a 78-year-old man. He's got a 14-year history of Parkinson's disease. He had motor symptoms first, and he was treated with levodopa or Sinemet. And he's been having increasing difficulties lately with his non-motor symptoms, and we'll talk about what some of those might be. He's needing more help with his activities of daily living. He's starting to have dysphagia. He's starting to have weight loss. And his wife, who is his primary caregiver, also has her own health concerns and her own health issues. And there is a concern that there's some caregiver burden going on there. So this would be a classic palliative care patient that we might get involved with. And we're going to kind of keep him in our mind as we go forward through the slides.
Okay, so as objective 1, we're going to briefly talk about what Parkinson's disease and related disorders are. Next, please. So Parkinsonism is a syndrome characterized by the core motor symptoms. You guys might remember the mnemonic TRAP, so TRAP. So T stands for tremor, R stands for rigidity, and then akinesia or bradykinesia, meaning that is slow movements, and postural instability. So Parkinson's disease is actually the most common cause of this Parkinsonism that we're talking about. And then it could also be seen in other types of neurodegenerative conditions. And then it could also be caused by medication that blocks the dopamine. And then I'm going to talk about a little more about that in a bit. Now, with new studies, we are discovering more and more how these entities are caused. And then we are more in understanding of how the misfolded protein that accumulates in the brain that causes this type of Parkinsonism or symptoms. Next, please. So broadly, Parkinsonism is divided into primary and secondary causes. We are going to talk a little bit about that. As a primary cause, the most common cause of Parkinsonism is a Parkinson's disease, as shown as PD in the figure. And then there are other types of Parkinsonism. We call that atypical Parkinsonism or Parkinson's related disorders. And then most common one of those are dementia with the Lewy body, multiple system atrophy, and then progressive supranuclear palsy, and then corticobasal degeneration. We will talk a little bit about those. And as I mentioned, there are some other neurodegenerative conditions that cause Parkinsonism, and then majority of those are actually hereditary. And as a secondary cause of Parkinsonism, one of them is vascular. So if a patient has a stroke that has a strategically targeting certain part of the brain, including basal ganglia, you could have symptom of Parkinsonism. and then also some medication, including antipsychotics, that could lead to Parkinsonism symptoms as well. Next, please. So the cause for the Parkinsonism, one of the most common causes of Parkinson's disease that occurs almost 1% in our population over the age of 60. So it is not uncommon. And then that incidence really increases with the age, and the mean age of onset is about 65 years old. And then if you look at the whole residents at the long-term care in Ontario and elsewhere in Canada, almost 10% of the residents are with the diagnosis of Parkinson's disease. So it's quite common. And then Parkinson's disease is largely caused sporadically, but 10%, so a small portion of that, is caused by genetic mutation. There are more males are with the Parkinson's disease compared to females. And then important thing is that Parkinson's disease is quite heterogeneous. They have a different clinical presentation. We'll talk about motor and non-motor symptoms, and then different age of onset, and then different types of symptoms, and then also different rates of progression as well. And then we understand that at the time of diagnosis, due to some of the symptoms, and then the patients with the Parkinson's disease usually have a mean survival of about 15 years. Next, please. So in terms of etiology, so Parkinson's disease occurs really due to progressive degeneration or loss of dopamine-producing neurons in an area called the substantia nigra within the midbrain. So this leads to lack of dopamine that's produced and then used up in basal ganglia of the brain that leads to impaired motor control and then coordination. And then it's also characterized by aggregation or accumulation of abnormal protein called alpha-synuclein, and the Lewy body, as we'll hear about the Lewy body dementia as well. And then this leads to neuronal dysfunction and then mitochondrial dysfunction, and then also inflammation as well. Next slide, please. And then diagnosis of Parkinson's disease is purely based on clinical presentation. So Parkinsonism is a really most important part of the diagnosis. So bradykinesia, which was one of the four most common, symptoms of a Parkinsonism. Of those four, bradykinesia or slow movement is the most important thing. And then plus their rigidity and then also resting tremor as well. It is important to note that the postural instability is not a part of the clinical diagnostic criteria because it is quite non-specific as well. It could happen in some other entities related to Parkinsonism or others as well. Clinically established Parkinson's disease, it requires a few more criteria. So one of them is absence of absolute exclusion criteria. I'm not going to go over all the criteria, a list of criteria, but basically these are the symptoms that might be seen in other entities with the Parkinsonism, such as atypical Parkinson's disease. And then some of the red flags that also present in other types of Parkinsonism. So these should be absolutely absent in presentation to diagnose as typical Parkinson's disease. There are some supportive criteria. One of them is good response to dopaminergic medication, including, for example, levodopa. So that is a gold standard of treatment of Parkinson's disease. And then also levodopa-induced dyskinesia is also important. And then one other thing I wanted to point out is that resting tremor. That's also very important supportive criteria to diagnose Parkinson's disease. Next slide, please. So this is just a little video to show how Parkinson's disease present in someone. So this video shows 67-year-old gentleman presenting with a resting tremor. So tremor at rest, not with the movement of the hand. And it is described as a pill rolling tremor. So really the pronation, supination, so rotating of the hand is a characteristic of this tremor. And then he also has a tremor while he's walking, and then has reduced arm swinging when he's walking as well. So those are the typical symptoms of a Parkinson's disease. And then this is a video for a patient who was diagnosed in Parkinson's disease. And then we can see some patient as well.
In 1976 at Duke University, actually off campus at a United Methodist Church covered dinner.
I don't remember much about when I actually met him, though. I met him across the potato salad, I guess. I just remember him as being, I guess, intellectual, but just very friendly and very warm.
We're blessed to have 3 wonderful children, all adults, and now 4 grandchildren. We added a 4th just 2 months ago, where those grandchildren, I just love to sit and watch them. It's fascinating. Life before Parkinson's is quite frankly hard to remember at this point. It's been quite a while. Parkinson's slowed me down, literally. We started to notice subtle changes. Ellen would say, "John, you're not swinging your right arm when you walk." She'd also ask me to repeat myself a lot. I was very concerned she was losing her hearing.
Right. He told me I just wasn't listening, or maybe I was going deaf. Yeah. So.
But I found out that's very common for Parkinson's pairs.
One thing that John noticed, and this is what caused him to go to our family doctor, was that he was having pain in his right shoulder. So then he sent us to the neurologist, and it was interesting. The neurologist said, "Has your writing gotten smaller?" And yes, and he said, is your family having more trouble hearing you? And we just started to laugh. So he was on to that sort of the typical signs of early Parkinson's.
First thing when I got the diagnosis, I was afraid. I wasn't familiar with the disease. Since then, I've learned that it's nothing to be afraid of.
Thank you. Next slide, please. So here, this patient was talking about several different symptoms, including motor symptoms and some non-motor symptoms as well. We'll go over each of these symptoms and how we can hopefully manage them as well later in the presentation. So briefly on atypical Parkinsonism or Parkinson's-related disorder. Next slide, please. So up to 15 to 20% of patients with a Parkinsonism, they present with atypical Parkinsonism, so atypical Parkinson's disease. And they are not quite similar to Parkinson's disease, but with much faster progression. And then they do not tend to respond really well to dopaminergic medications. So they are typically treated with a levodopa or other dopaminergic medication, but their responsiveness is not quite same as typical Parkinson's disease. And then they are due to different pathological causes, namely different abnormal protein aggregation or accumulation. That does explain why this treatment often do not work. Next slide, please. So I will briefly talk about 4 different atypical Parkinsonism that we commonly seen in our community. One of them is a progressive supranuclear palsy. So in addition to, so each one of these entities have specific characteristic features in addition to typical Parkinsonism. So in case of PSP, they do have a very early falls and then very severe postural instability. They could have a tremor and other symptoms of a Parkinsonism, but these symptoms come earlier. They especially they have difficulty moving their eyes. And then also they have features of this surprised look, as you can see in this photo. And then they have a profound dysphagia and then also communication difficulty as well. Those are the ones that we need to keep in mind when we care for these patients. Next, please. Corticobasal degeneration. So these patients, they do have a Parkinsonism, but in addition to that, they have something called apraxia. So it is the inability to perform the skills they have already learned in the past. So as you can see in this illustration, this is showing dressing apraxia, so unable to put on their dresses. So that type of symptoms. And then also some cortical sensory problem, myoclonus, which means brief jerking movements, and then alien limb phenomena. So they're almost similar to apraxia, but from the other perspective, their body can move without them realizing, or they are being in control as well. And then they do have some cognitive behavioral changes as well. And in multiple system atrophy, there are with profound autonomic dysfunction. So you may have seen the patients with a profound orthostatic hypotension, and they are ambulation or even physical activity is quite limited due to that. And then they have bladder and bowel dysfunction, even though they are seen in other types of a Parkinsonism, but they do have a profound and a very severe symptoms of these. And they also have very severe cerebellar ataxia, so that impacts their ambulation and gait and then leading to falls as well. Lastly, dementia with the Lewy body. They are with Parkinsonism, but their cognitive decline comes quite early in their progression. So we say that if the dementia or cognitive decline comes within the 12 months since starting their motor symptoms, we really need to look into the possibility of a dementia with Lewy body. And then these patients do have quite vivid visual hallucination as well. That might be quite distressing.
Dr. Kim, I do have one question here.
Yeah,
Would
absolutely.
you view Parkinson's disease as a type of brain failure, like you might view Alzheimer's disease as a type of brain failure?
Actually, in fact, Alzheimer's disease are characterized by accumulation of abnormal protein as well, so beta amyloid. And then we understand that Parkinson's disease and other related disorder are also due to accumulation of this toxic or abnormal protein and then misfolding into Lewy body. This causes neurodegeneration. So more so degeneration of the neuronal function that causes the Parkinson's disease and the Parkinsonism.
And a similar question, someone I talked to was describing PD as primarily and above all a motor disease. Would you say that's accurate?
So some of the Parkinsonism do have quite profound motor symptoms. However, there are with the motor and several non-motor symptoms. We will actually get into in details about these non-motor symptoms and how we can address them.
Thanks. That's great.
Okay. And then briefly on medications for Parkinson's disease. So because Parkinson's disease is due to loss of the dopaminergic neuron, the main course of treatment of this disease is to replace the dopamine. So the purpose of treating this Parkinson's disease is not to change the course of the disease. Unfortunately, we do not yet have disease-modifying therapy. However, these medication can help with those motor symptoms. So one of the most common medication that we use, or in fact, the gold standard of medication is called levodopa and also called Sinemet. And then they replace dopamine, and then they are released from the presynaptic neuron, as you can see in this photo, and then they are used in the postsynaptic neurons in basal ganglia, and then lead to better motor control and then coordination as well. The important part of levodopa is that they tend to become less effective over time. So you may have seen the patients, they have to accumulate or increase the dose or frequency of the levodopa use. However, their effectiveness becomes less and less obvious. There are, amongst the other Parkinson's disease medications, they are safest in the elderly patients. However, there is a key adverse effect, that is dyskinesia. Next slide, please. So dyskinesia, especially peak dose dyskinesia, which means that the peak dose after taking the levodopa medication is quite distressing. And then dyskinesia is described by this abnormal hyperkinetic movements, involuntary, and then often dance-like, fluid-like movements as well. That could actually lead to quite a distressing in these patients. And then, as we talked about, the levodopa medication or any other dopaminergic medication are often less effective in atypical Parkinsonism. Okay, next slide, please. And then these are the list of medications. So levodopa, carbidopa, that's the gold standard medications. And then there are MAO inhibitors and COMT inhibitors. Those are the medications that can prolong the availability of levodopa in our body. And there are several medication example of these medications. And then dopamine receptor agonist, For example, pramipexole or rotigotine patch, which we'll talk about later on. And those are also examples that we use quite often. Amantadine at the bottom of this table, that's also medication that we often use for Parkinson's disease, especially for those peak dose dyskinesia. And however, it causes quite a significant somnolence and confusion, and we try to avoid using those medication in elderly patients. And then I will talk about some of the side effects later on the slides. And then one other important factor, and then I guess treatment modality is deep brain stimulation. It is for certain type of patients, especially with severe motor fluctuation and a severe off-time symptoms. So off-time symptom means that when you take a medication, you have a quite a bit of effect from the medication in motor control. However, as the medication weans off or the effect comes off before the next dose, then you have a return of these symptoms. If those are severe and difficult to manage with the frequency change and dose changing of the medication, then deep brain stimulation might be very effective way to control these. And then also tremor that are quite resistant to any other dopaminergic medication that would be a good candidate for deep brain stimulation as well. And then basically in this procedure, they insult the lead to stimulate a certain part of the basal ganglia, specifically subthalamic nucleus and globus pallidus internus, to stimulate the function of those neurons to lead to better motor control and coordination. Next slide, please.
Okay, so I'm going to jump in and talk a little bit about disease trajectory in Parkinson's disease and Parkinson's related disorders. Before I do, I just wanted to mention, I don't think we have any more videos, so don't stress about finding the sounds or anything like that. Really, the videos that you were just seeing were more for you to see what the tremors and the dyskinesias look like.
Thanks, Christine.
No worries. Okay, so in general, patients with Parkinson's disease and Parkinson's related disorders tend to have a lot of symptoms, both motor and non-motor. You can see them on the slide here. The ones that Woojin were talking about, the tremor, the rigidity, and the bradykinesia, tend to be kind of what is defined as early stages and tends to be what kind of leads to the diagnosis. But there are many symptoms that people kind of experience early and before kind of they're diagnosed. And that includes things like gastrointestinal symptoms. It includes things like mood. It includes things like sleep issues. And we'll talk about some of the specifics of those symptoms as we go through. As Parkinson's advances, you do see a lot more both motor and non-motor symptoms, including things like dysphagia and urinary symptoms, hypotension and orthostatic hypotension. Often that leads to a lot of falls. You can see cognitive impairments in the later stage, and you do get a lot of psychiatric symptoms as well, including psychosis and hallucinations. I will mention that in general, this presentation and the things that you see in the later stages tend to come much faster in these Parkinson's related disorders or atypical Parkinsonisms. So you often see the disease progressing a lot faster in those compared to Parkinson's disease. In general, why patients with Parkinson's disease die. The majority of cases, in many cases, as many as a third, are related to aspiration pneumonia, so developing that dysphagia that comes with the later stage Parkinson's disease. They often have reduced mobility, often have falls. There are a proportion of patients that have like a sudden death or arrhythmia. There's a lot of infection related, sepsis and those kinds of things, and there are some people that have some general deterioration. Parkinson's disease in general is often thought of something that you die with and not of. I would say if you're dying of Parkinson's disease, it's usually related to like a fall, an aspiration, or something like that. But then you may also have been living with Parkinson's for 10 years and develop another issue or have other medical problems that are causing your decline as well. One of the biggest challenges with Parkinson's disease is that the prognosis is very variable. As Wujin said, the mean time with Parkinson's disease is about 15 years, but there are people that have lived with it for a very short period of time, and there are people that live with it for much longer. And there's this, everybody's a bit different. So everybody progresses differently, everybody lives with it differently. And often you'll see like a bit of a decline, a plateau, and then another decline. And it's really hard to kind of get a sense of really how things are changing over time. And it really kind of muddies the water when it comes to prognosis. The other issue is the people that are following you tend to have a long-term relationship with you. And so it's hard to notice those like key step points along the way, those key trigger points in the decline. And so that can be a bit tricky as well. This is a project that both Wujin and I have worked on, where we looked at using like high-level administrative data. We looked at all of the patients with Parkinson's disease, so not the atypical Parkinson's disease proper, who died with Parkinson's disease, and looked at how they received palliative care, what their healthcare utilization looked like in the last year of their life. And this is a bit of a busy slide, but what I'll draw your attention to is this blue line. On the left panel here, this is everybody that died that didn't have Parkinson's, and then on the right is everybody that died that did have Parkinson's. And you can see there's a significantly higher proportion of patients who received long-term care, or who resided in long-term care at the time in the last year of their life. There is also a significantly higher proportion of people in the Parkinson's cohort who had home-based care, not necessarily from a physician, but who needed a lot of things that you would imagine, like PSWs, nursing support, and those kinds of things in the home. In both cases, in patients who didn't have Parkinson's and who did, both of them you see in the last kind of weeks of life, the home-based physician care went up kind of significantly, and that's that red line here that you're seeing go up. So we're going to talk a little bit about Objective 3, and we have some polls for you here. We're going to talk about what the palliative care needs are in Parkinson's disease, and so this is going to be kind of both how we can serve people and also kind of how we can manage their symptoms best. So we have a poll to start. So the question is, what proportion of patients with Parkinson's disease receive palliative care outside of long-term care? Okay, so yeah, so it seems like everybody on this call is a little bit pessimistic. So there was kind of an equal split between 10% and 35%. And for the people who chose 35%, good for you, you're right. And I should clarify that this is the proportion of patients that receive any sort of palliative care. So not necessarily physician-based palliative care, but palliative care from nursing, palliative care from in a palliative context. Going back to this study, we've shown that Parkinson's disease in general, patients with Parkinson's disease have higher home care needs, higher healthcare costs in the last year of their life. Having any sort of home-based palliative care is likely to decrease the risk of dying in hospital or dying in an acute care setting. And while we talked about 35% of patients outside of long-term care receiving any sort of palliative care, only about 20 receive palliative care from a physician in their home. And usually it's only in the last few weeks of life. I again should mention that this is all just Parkinson's disease. The Parkinson's related disorders are not there. And so, yeah, like I said, we showed more people admitted to long-term care, 52% versus 23% in the general population, which is a significantly different number. Receiving a lot more days of home care, having a lower odds of dying in hospital if Parkinson's disease was involved. And as we talked about in terms of cost, you can see the cost there, $68,000 a year versus $59,000 in the last year of life. When it comes to the Parkinson's related disorders, this is a great read for anybody that's interested in learning more about the palliative care of atypical Parkinson syndromes. The take-homes of this article are essentially saying how we need to shift our involvement in palliative care in these disorders. So they're suggesting they need earlier palliative care, more integrated palliative care with neurology, more early advanced care planning, holistic symptom management, supporting caregivers, but there's actually no information about how we're actually doing when it comes to delivering palliative care in these patients. So a good read, but unfortunately we don't really have a great understanding of how palliative care is delivered in these patients. And I'm going to pass it back to Woojin for a little bit of symptom management.
Thank you, Christine. So we're going to talk a little bit about the symptom management. Next slide, please. So as Christine mentioned, that even from the time of diagnosis of Parkinson's usually happens because of the motor symptoms, like a tremor, like slow movement or rigidity. And then that's where what it shows right here in the middle of the slides. There are several other symptoms that may begin way before the onset of the motor symptoms. So we now understand more and more that some of the autonomic symptoms, including constipation or hyposmia, meaning that difficulty smelling, can occur 5, 10, even 15 years before the onset of a motor symptoms. And then REMs here on the left of the slide represents rapid eye movements or REM sleep behavioral disorder. So I guess it says entire the term here. So it is a type of sleep disorder where patients act out of dream. So they scream or kick or punch out of dream, even though they are in a REM, a level of sleep where you have to have, you're supposed to lose any muscle tone. So that type of sleep abnormality can occur 10 to 20 years before the onset of motor symptoms. And then they are actually correlated to high, percentage rate of diagnosis of Parkinsonism later in life. So those are quite specific type of non-motor symptoms that occur in this population. And then as disease progresses, as you follow along the slide from the middle to the right hand, there are accumulation of all these symptoms. So both non-motor symptoms and motor symptoms. And sometimes the symptoms are related to the medication. As much as we wish that medication are, sort of a magic pills, but all the medication that we use for other conditions, but also Parkinson's disease, they come with certain side effects. And then patients can accumulate these symptoms due to those use of the medication as well. Next slide, please. Studies find that most Parkinson's disease patients, they have average of 8 or more non-motor symptoms. And then these include fatigue, pain, and then constipation, sleep problem, anxiety, some cognitive problem, and then vivid dreams, and then difficulty managing their moods, and then also poor appetite, nausea, some GI problem as well. And then these are important because non-motor symptoms are often under-recognized. The motor symptoms are quick to recognize and treat, but these non-motor symptoms are important but less recognized. And then they are often more difficult to treat them. And then they clearly impair quality of life in these patients, often so more than the motor symptoms. And then they really impact on caregiver. They put an impact on caregiver burden as well. And then these symptom burden in advanced or later stage of a Parkinson's disease is almost similar to those with a metastatic cancer. So we can imagine how burdensome they could be. And then often treating these non-motor symptoms are less responsive to medications, and then they could accumulate more side effect rather than treating these symptoms, unfortunately. Next slide, please. So there has been recent Canadian guideline published for Parkinson's disease. It was published in 2019. So we are waiting for the new edition of this guideline as well. And then the guideline talks about many different things. They provide helpful information on diagnosis of Parkinson's disease and then prognosis and then how to communicate with the patients and the caregiver. And then most importantly, some of the suggestion or guidance on treating these motor and non-motor symptoms. And then also for the first time in the guideline for Parkinson's disease, they begin to talk about palliative care for this population. Next slide, please. And then this might be a good read for those of you who are interested as well. Oh, we can skip over to the next slide. Thank you. So in terms of motor symptoms, so guidelines recommend certain use of certain medication for the motor symptoms, And then this is how typical Parkinson's disease is treated for their motor symptoms. So as we can look at, see the green, orange to pink. So early, stable, or so moderate stage, and then advanced stage of a Parkinson's disease. Levodopa is a gold standard method of treatment, and then they could be used from early on of the disease trajectory up until advanced stage as well. There are several other medications, including dopamine agonists. They include example like pramipexole or rotigotine patch, and then MAO-B inhibitor and COMT inhibitor. Those are the medications that prolongs availability of a levodopa. And then examples are solageline, razageline, and then entacapone. You may have come across those medications, but those are often used as an adjunctive medication to levodopa and dopamine agonist, with the exception of a MAO-B inhibitor. In certain cases, that could be used as a single agent in an early phase of the disease as well. Amantadine is a medication we often use for peak dose dyskinesia, and then they are typically used or reserved for the use in the advanced stage of the Parkinson's. And then there is a deep brain stimulation, and then also intestinal gel infusion of the levodopa, which is called duodopa as well. And then these are also reserved for the advanced stage of the Parkinsonism, and then they are quite effective for in controlling motor symptoms as well. There are some common side effects that could be caused by many of these medications. Next, please. So these include the GI upset side effect and the nausea, and then some orthostatic hypotension as well. And then we will get into more details about these symptoms and how we manage it. But if these symptoms occur due to the medication use, domperidone is typical medication we often combine with the levodopa or dopamine agonist to mitigate these symptoms. And an impulse control disorder and sleep attack, hallucination, or confusion, that could be also occurring in many of these medications, but especially in dopamine agonist. Especially impulse control disorder, we estimate that almost 50% of patients who are treated with dopamine agonists can develop impulse control disorder within about 5 years. So these, unfortunately, if this occurs, then that will be the indication to stop medication. And a sleep attack, and then patient could quickly fall asleep even during the day. That could be the sign of a side effect of this medication as well. And as we talked about dyskinesia, levodopa is really the main medication that will lead to dyskinesia. And amantadine, we can use that as a extended release amantadine from 100 to 400 milligram. But with this side effect, it is really important to consulting with the neurologist is really important.
Dr. Kim, there is a question about tics or Tourette's. Is it associated with Parkinson's at all?
Not to my knowledge. Tics and Tourette's are usually or conditions that develop from the early on their lifetime, and then especially Tourette is a mixed or combination of different types of tics, and then based on how long this condition lasted beyond a certain age. And then Parkinson's disease are the condition that occurs later in life. However, there are some symptoms that might mimic tics or Tourette's. However, they are not clearly associated entities.
And someone is asking also a concern question. Are you for sure going to get Parkinson's if you have REM sleep disorder behaviors?
Yes, so we estimate that approximately 80 to 90% of patients who have the REM sleep behavior disorder early in life will end up developing a disease associated with a Parkinsonism, especially certain diseases that are related to certain type of protein called alpha-synuclein. So it is quite sensitive. However, not specific as well, but not 100% specific for Parkinson's disease itself, but it is quite important. Like no motor symptoms we need to monitor for sure.
Yes, thanks.
Yeah. So here's a question. This is not a poll, but can anybody tell us how we can safely start levodopa carbidopa, also called Sinemet? And then you can feel free to write in the chat or speak up, but I'm also happy to get into the answer as well. It's not a trivia, but Sinemet means it is a brand name for combination medication of levodopa, carbidopa. Levodopa, as I mentioned, that it is the medication that replaces dopamine. Carbidopa is the one that blocks dopamine uptake in our GI system. So Sinemet, essentially the name was developed, sin as without, emet as in emesis, so without nausea or vomiting. So that's what it intends to describe the combination of, or role of combination of levodopa and carbidopa. So that's a fun fact.
Mm-hmm.
Go back. So
Mm-hmm.
we typically start Sinemet slowly, absolutely. And then, for example, 100 levodopa and 25 milligram of carbidopa, half tab 3 times a day with the food, because their GI symptom or side effect could be quite severe. And then slowly increase by half tab every day, every 3 to 5 days, up to 1 tab 3 times a day to see their effect on their motor symptoms. So if I can write it out in prescription or in details, for example, they take half tab 3 times a day for 5 days, increase to 1 tab, half tab for 5 days, increase to 1 tab twice a day, plus half tab for 5 days, and then 3 tabs 3 times a day for 5 days to finally evaluate their motor symptoms. And then throughout this process, you can monitor their common side effect like a GI, symptom, upset, nausea, and then also confusion, hallucination, and also dyskinesia as well. And then I'll hand it over to Christine.
Okay, we're gonna dive right in with a poll. So we just talked a little bit about the motor symptoms of Parkinson's disease. I'm going to talk a little bit about some of the non-motor symptoms. And so we're going to start talking about constipation. So we have a 90-year-old man. He has Parkinson's. He's had it for 20 years, and he's admitted to the hospital with constipation, with no bowel movement for the last 5 days. He's been in to the hospital for the same thing 3 times in the last year. And this is a evidence-based question. So what medication has the best evidence to treat Parkinson's, to treat constipation and Parkinson's disease? Okay, so it's a bit split between PEG 3350 or Laxaday, polyethylene glycol, and Senna or some other stimulant. And the answer is actually so polyethylene glycol, so has the best evidence. You can use lots of different things though, as we're kind of used to individualizing it for our patients. So Laxaday has the best evidence for efficacy. You can use lactulose. You can use a stimulant like Senna. We do see that sometimes people use domperidone for kind of that prokinetic action, though that's usually kind of more in the foregut that we see that. But it's also important to take a look at medications and say, okay, are they on anything that's going to make them constipated? So reducing anticholinergic medications and other constipating medications. I have a lot of patients who like to use like Metamucil or psyllium fibers and those kinds of things. Important to remember that these medications cause a lot of bulk in the bowel. If they're not drinking well, or if they're not moving as much and the fiber, the supplemental fiber is just kind of sitting in the bowel, it really can just kind of turn to concrete. It can really actually make the problem a bit worse. So we tend to try to avoid that as much as possible. And this is your quick reminder to say that polyethylene glycol, Laxaday, Restoralax, whatever you call it, cannot be put into starch-based thickeners. So that's including things like Thicken Up. And the reason why is there's some sort of chemical reaction where they actually kind of precipitate and the fluid becomes unthickened. So this becomes a big problem in our patients with like later stage Parkinson's disease who have some dysphagia and who routinely take thickened fluids. You want to kind of make sure that if you're giving a laxative, it's not PEG in this case. So you can use a liquid thickener, but not a starch-based thickener. And so yes, I do see in the chat also diet and good water, very important to assess. Absolutely, always very important to assess. So thanks for pointing that out. We're just going to do poll after poll after poll here. So everybody kind of get your polls ready. So this patient, in addition to being constipated, is also very nauseated. So what is the best medication to treat nausea and Parkinson's disease?
Okay, there's the results.
Okay, so it's great to see some different opinions here. So metoclopramide, 29%, domperidone, about 50% of people, and then smaller numbers for both olanzapine and ondansetron. And the answer in this case is domperidone. So I'll chat through that. Metoclopramide, domperidone, and olanzapine are all antidopaminergic medications as well. Metoclopramide and domperidone are really thought of as that kind of like prokinetic aspect. The difference between A and B, so metoclopramide tends to cross the blood-brain barrier and domperidone does not. And so in patients who already have a deficiency of dopamine, we don't want to take more dopamine away. So we want to avoid antidopaminergic medications in the brain as much as possible. So that kind of kicks out metoclopramide as well as olanzapine, which is a strong antidopaminergic medication. Domperidone, like I said, doesn't cross the blood-brain barrier, but just an important piece to say that it doesn't have an injectable form. So if your patient is having a lot of vomiting and those kinds of things, it can be a bit challenging. A note on ondansetron, it's not antidopaminergic and can be used both as an oral medication and as an injectable medication in this patient population, but it tends to be really constipating. So it's not our first line, especially in a patient who already has issues with constipation or who might be prone to constipation. All right, we're going to talk a little bit about sleep now. So we have a 64-year-old lady who had some early onset Parkinson's disease. She was diagnosed 8 years ago, poor sleep and daytime fatigue. So we're going to talk about the medication with the best evidence to treat sleep disturbances in Parkinson's disease. So you've got a few options, including trazodone, Ativan or lorazepam, melatonin, and zopiclone. Okay, so equal split for the first choice between trazodone and melatonin. I love that that is the case. The answer is actually melatonin. So whereas that's not always our go-to on the palliative care unit, it's actually, there is some good evidence for melatonin in Parkinson's disease. So kind of before we talk about medications at all, important that we're optimizing good sleep hygiene. That is absolutely essential in all of our patients, also in Parkinson's patients. You want to manage symptoms of things that might wake them up at night, things like overactive bladder, which is common. And it's also important to say, like, are they on the appropriate dose of Parkinson's medications? Is there levodopa in an optimal state? You know, are we kind of maximizing that as well? I see in the chat, the question is like, what dose of melatonin? I would start with 5. I go up to 10 at night. It can be safely used. You can use trazodone for the record. It's just not as, there's not as much evidence in favor. What about mirtazapine? You can use mirtazapine. I mean, I have used mirtazapine. It's not a go-to. There's not a lot of evidence to support the use of mirtazapine generally in any palliative care patient. It's not because it doesn't work, but it's just because it's not been fully studied and it's a challenging thing to study. There's no specific contraindication, but it wouldn't be the one with like the most evidence base, I would say. I certainly wouldn't start it before I start other medications. Yeah, exactly. So it would also be important to assess for worsening motor symptoms at night. So exactly, yeah. And we'll talk about restless leg. Restless leg syndrome in Parkinson's disease is extremely common. There's a few things that we can do for that. One is obviously to assess for iron deficiency and treat any iron deficiency. If it is there, you're having target ferritin levels above 75. When it comes to what we would use, often people think, okay, well, maybe they just need more levodopa, maybe they need pamiprexol, which is a dopamine agonist and a medication that we often give in patients with restless leg syndrome who don't have Parkinson's disease. These actually aren't recommended because it actually can worsen the symptoms sometimes. Instead, we use things like gabapentin or gabapentinoids. There is some talk of using like low dose opioids at bedtime. And just to note that things like SSRIs, antihistamines, and antipsychotics can worsen restless leg syndrome. So if you have been augmenting some of these medications and all of a sudden that restless leg symptoms are getting a lot worse, important to take a look at some of those things as well. Okay. We have another poll. So we have an 89-year-old here with Parkinson's disease who has new onset paranoid delusions and hallucinations. And the question here is a little bit of a like, all of these things are true except. So the first step in management may include all of the following medication or all of the following things except for, would you do a clinical assessment for reversible causes of hallucinations, reduce dopamine agonists, reduce anticholinergic medications, or reduce levodopa? So you can do all of those things except one.
Okay.
Okay. Yeah, so it's a bit of a mixed bag here in terms of the answers. The most common answer at 41% was a reduction of levodopa, and that is the right answer. So when you have a patient who has new onset paranoid delusions and hallucinations, this is a nice like schematic that came up. This was in the Canadian Family Physician Magazine, but it's based on the clinical practice guidelines that Woojin showed before. Certainly, you know, you can look for it would be very appropriate to look for like a clinical change, whether there's an infection or something else that might be causing these new onset hallucinations. In general, when you have all of these other medications that have been added outside of levodopa, thinking about taking some of those away first in this kind of hierarchy is generally what's recommended. And then, so we have this patient who's got these new hallucinations, they're distressing. What medication might we use to manage the symptoms? And this is the medication we're looking for here is the medication with the best evidence for managing paranoid delusions and hallucinations in Parkinson's disease. Okay, so 57% of people say quetiapine or Seroquel is their kind of first choice. Second is clozapine at 24% of the population. And this is like an unfair kind of trick question, but I think worthwhile discussing. Clozapine actually has the best evidence for the management of delusions and hallucinations in Parkinson's disease, but we very rarely use it. And the reason why we very rarely use it is because it requires drug monitoring for toxicity and those kinds of things, which can be challenging. Importantly, when we're talking about antipsychotics in Parkinson's disease and managing hallucinations and delusions, we're only managing things that are distressing, that's causing challenges with safety or quality of life. And we want to avoid medications that are strongly antidopaminergic because our patients are already kind of needing supplemental dopamine. And so that would be avoiding things like olanzapine, haloperidol, methyltrimeprazine, or Nozanan, if possible. And certainly the strongest ones. Now, clozapine has the best evidence, but we don't really use it. Quetiapine or Seroquel is easy, it's safe, it's easy to give. As for the Canadian Parkinson's guidelines that we talked about, it actually says like all other antipsychotics should be avoided. Now, the challenge with that is Seroquel is a medication that's only taken orally. If our patients are needing injectable medications, it can be really challenging to know kind of where to go when these patients need something, aren't taking anything by mouth, maybe have dysphagia, maybe you're too agitated to do something about that. It's like, what do we do from here? Often, instead of adding antidopaminergic meds, we think about reducing dopaminergic meds. So instead of giving a medication that will block dopamine, we just take away some of the dopamine we're giving them. And so that's often a good place to start, is to kind of look at the meds that they're getting for their Parkinson's disease and reducing some of that, as we kind of showed in the hierarchy before. And then other options that you would have are things like benzodiazepines. So you can give midazolam, lorazepam. Midazolam is an injectable option. You can give alpha agonists, which can help with agitation. Those include things like clonidine orally or dexmedetomidine, usually only in a specialized setting, though.
Christine, what
Yeah.
about recommendation for end-of-life delirium?
That's a great question that we will get to if you're willing to hold on for just a second.
Good.
What would you do with a patient that has Parkinson's disease and bipolar or schizophrenia? A great question that I would consult my neurologist and psychiatrist together, but it's extremely, extremely challenging because almost all antipsychotic medications and management here has an antidopaminergic effect, and so it can be really, really challenging. I don't know, Woojin, if you've ever had a clinical case of that, and maybe you could share kind of how you went about that in the neurology hat.
Yeah, I mean, it is extremely challenging. We discuss a lot with psychiatrists and then also everybody else who's involved in the care as well. Most important thing I would say is that we have to make sure that the Parkinsonism is not due to the use of the antipsychotic. And then that is the most important part. Yeah.
Right.
Okay. So we're going to talk, we'll get back to the end of life care stuff that does come up, but I'll touch briefly on sialorrhea. So patients with Parkinson's disease often have or can have issues with sialorrhea, so a lot of salivation in the mouth. There are some non-pharmacological treatments, including kind of increasing the head of the bed for nighttime salivation, sugar-free chewing gum or hard candy and those kinds of things. Pharmacological treatments usually include optimizing their dopaminergic medications. It's always first line, in case you guys haven't realized that yet. It's like, what's going on with our dopaminergic medications? So that's first. The easiest next step after that is sublingual atropine, which is actually given as it's actually an eye drop that you can give kind of sublingually. You can also use different anticholinergic medications, including amitriptyline orally, with the major side effect being dry mouth. So kind of using that side effect to our benefit. And then in more challenging cases, things like injectable glycopyrrolate. You can also have Botox injections into the salivary glands to help with sialorrhea. That is something that our neurologists here in Ottawa will do. Typically, though, they will kind of do that sparingly and make sure other things are maximized, just because there is a not zero risk of worsening any dysphagia that might exist. Though I think that that's a pretty rare that we see that. One of the other big non-motor symptoms that we struggle with in kind of later stage Parkinson's disease specifically is the orthostatic hypotension. And so patients that become either lightheaded and have a blood pressure drop when they go acutely from laying to sitting, from sitting to standing. And there's both pharmacological and non-pharmacological options. So from the non-pharmacological approach, and this should be the gold standard for everybody, it's like making sure they're drinking enough and making sure they're drinking things with electrolytes. So Gatorade, Powerade, coconut water, V8. A lot of people like V8. Make sure that they're having like their head of their bed, they're not elevated, they're not fully flat all the time. Kind of trying to do a lot of cueing and education around when they actually do move. So when they sit up slowly, dangle your legs, pump your legs, try to get some of that blood moving before you stand up. Some people use like abdominal compression bands. And then this always becomes much more of a challenge in the summer when the weather is hot, when you're losing more fluid due to sweating and those kinds of things. So avoiding prolonged exposure to the hot weather and making sure you're staying in like an air-conditioned environment. We do see often postprandial hypotension. So people who eat really like big carbohydrate heavy meals tend to have a bit of, after they eat, have a bit of hypotension. So trying to eat small, more low carb meals kind of throughout the day, if that becomes a problem, or if there's a specific trigger around mealtime. When it comes to medications or pharmacological medications, obviously check to make sure that they're on blood pressure medications. If they are, think about taking them away. Look if they're on any other medications that may have the side effect of blood pressure management. And so a lot of the medications that people would use for like overactive bladder, prostate related things, they can actually affect blood pressure as well. So just taking a good look at your medications, consulting with a pharmacist if you're not sure, getting the family physician or anybody else to just kind of review that. Liberalizing the amount of salt that somebody's taking, or giving them salt tablets to try to keep that up. Good news to me that there's actually evidence for caffeine here. So 1 or 2 cups of coffee a day. And then if those things are failing, you have the options that are listed here, both as midridine, fluorocortisone, or pyridostigmine, and the doses are listed there. Okay, I'm going to hand it back to Woojin. He's going to talk a little bit more about end-of-life care.
So when a patient gets into end-of-life care, next slide, please. So as Kristen mentioned, the disease trajectory, as the patients become or gets into late stage of Parkinson's disease, their symptoms accumulate quite a bit. It's a combination of a motor symptom, non-motor symptoms, and then also the symptoms related to the medication use, and then their functional and then clinical status decline as well. And then the common reasons for the patients to enter into end-of-life care is one of these listed here on the slide. So really inability to swallow, and then inability to eat and then maintain their nutritional requirements. And then because of the stiffness or difficulty coordinating the muscle, that is a really true reason why the patients have trouble swallowing. And then due to that reason, they could also have recurrent aspiration and leading to respiratory distress and a failure. And then also recurrent infections as well, from aspiration leading to lung infection, and also due to immobility, a patient can develop the skin infection, pressure ulcer related infection as well, and then also urinary tract infection as well. And then they do also develop other comorbid conditions like either cardiac, respiratory, and other things. Even though the Parkinson's disease doesn't mean that they have a propensity to develop other major organ failure, but they do also develop other comorbid conditions. They could be the reason why they get into end-of-life care. And then I believe Kristen alluded to this as well. The reasons why the patients with the Parkinson's disease get into terminal admission to the hospital is mostly due to one of these common reasons that I talked about, leading to severe infection, so aspiration pneumonia, or reduced mobility leading to falls, and then also just the general deterioration, and then also sepsis as well. Here's a poll. I am loving the poll as well. This is my first poll. So we have a 76-year-old male with Parkinson's disease diagnosed 10 years ago. There has been progressive motor symptoms and autonomic dysfunction. He's growing weaker and has had several falls over the past year. He's admitted to hospital as he's no longer able to manage at home. He's having difficulty managing any of his PO meds, and then also food as well. And what would the next best option for management? You could only choose one. So convert all medication to transdermal rotigotine, and then convert all medication to short-acting levodopa and give crushed to the patient, and then stop all other PO meds, and then all of the above. I believe it means that convert all meds for Parkinson's disease. Mm-hmm. Okay, that's great. So 22 out of 48 of you answered all of the above. So it is always all of the above when we have a question like this. So I'm going to describe this, why that is. So most important part when patients get to a clinical status where they cannot swallow medication is not to discontinue Parkinson's medication abruptly, because that can lead into quite significant distress, and then also condition where they suddenly lack dopaminergic input, and then they can lead to something similar to neuroleptic malignant syndrome, and then also dopamine withdrawal syndrome. So that is quite severe condition where a patient can be in critical status just because of stopping dopaminergic medication. So transitioning into some other method to provide dopaminergic medication is very important. So both Kristen and I worked on this scoping review to look at the literature and see how other people in the world, they manage these patients who cannot safely take oral medication in the last or late stage of the Parkinson's disease because of this risk. And then we do have lack of availability of other options. So one option is really crushing Sinemet or levodopa carbidopa and then giving to the patient. And then if they cannot really swallow, a lot of patients actually end up having NG tube and just to get those medications into their body and then slowly taper off. But other option is to use dopaminergic dopamine agonist, rotigotine, in transdermal patch form. So in this scoping review, we saw that so many literatures described the successful use of using rotigotine patch in patients towards the end of life, and also apomorphine subcutaneous injection as well. We do now have this available in Canada, but because of the need for very frequent injection into these patients, because the apomorphine is a very short-acting medication, dopamine agonist. So many centers and many community settings, what we do in practice is usually transitioning the medication into rotigotine patch. However, we are really lacking the evidence, and then we don't have a randomized control trial or large data to prove the efficacy. All this, evidence that we found on the scoping review was based on case studies. So to convert some of the dopaminergic medication into the right amount of a rotigotine patch, that is important because too much of a rotigotine patch can lead to delirium, other side effect of dopamine agonist, but too lack of or a little bit or less of the dose that we use with respect to how much dopaminergic medication they were on before, that could lead to worsening their motor symptoms. So there used to be a calculator that was considered as a gold standard. It is no longer available, unfortunately. However, there are several other calculators available online. This is one example. You can get into and use it, and they convert any of the dopaminergic medication, including Sinemet or any other dopamine agonist, in combination, calculate the dose, and then propose appropriate dose to start for rotigotine patch.
Dr. Kim, that's a great suggestion. We have a speech language pathologist asking a question with regards to how to be a better advocate for these changes. I'll let you read all of that, yeah.
Yes, thank you, Sylvia, for the question. So I'm a speech language pathologist working constantly with the PD patients, and I can never succeed in recommending changing different ways to administer meds versus large pills. How can I better advocate? I think we're going to get into the details about this conversation that's needed in Parkinson's patients, because traditionally we often have this conversation when the crisis happens, and then we involve a palliative care team, whether it's an MD or physician or non-physician palliative care team at the time of crisis. I believe, and we do have evidence that having this conversation early on in the disease trajectory, and then provide understanding of how disease may progress and then what potential symptoms they may encounter, and then having this expectation or discussion early on is really, really helpful. So that would be my one suggestion for that. And then there's another question on top of laryngeal penetration and the aspiration, they dissolve in a wrong part of the tract and cause severe ulceration. Okay, that is really good to know. Thank you very much.
That just helps us advocate better with
Yes.
that piece of information. I will add, just when it comes to the rotigotine patch, an interesting thing about it is actually, depending on where you work, it's not available on formulary at the Ottawa Hospital right now. So despite the fact that it's really the only medication we have that's easily accessible for kind of end of life, it's actually not available on formulary at the Ottawa Hospital. Sometimes we write outpatient prescriptions and the family go and fill them and bring them in and we're able to give it.
Yes.
Mm.
Thank you very much, Christine. Next slide, please. So another poll. So here we have a Mr. T. Mr. T continues to decline and he's approaching end of life. He develops delirium and is increasingly restless and agitated. All Parkinson's disease medication have been stopped and then transitioned into appropriate dose of rotigotine patch, let's say that. And then what is now the next best option for management? I believe this would answer the question that we had earlier.
Yes.
Okay, so I think everybody's on the track now. So all of the above, that is the answer. 26 out of 47 of you answered this correctly. So all of the above. So the main reason is that we do not really have good evidence behind this. And then also important part is that when patients with the Parkinson's approach their end of life, their motor symptoms actually do not appear to be major concern for their distress, fortunately. So use of medications such as Nozinan, which could lead to worsening of their motor symptoms, don't seem to cause them significant distress at this stage of their life. And then other medications such as benzodiazepine, midazolam, lorazepam that we often use in the palliative care setting. And then also other medications such as clonidine and dexmedetomidine could be good medication to manage their end of terminal delirium. And then phenobarbital also would be a good option. Actually, we do have a project actually led by Christine here at Breeder Palliative Care Unit. We are actually, and then also the Ottawa Hospital, we're looking into how these patients who are transitioned to transdermal rotigotine patch, and then they're approaching the end of life, how they're, the Parkinson's symptoms and then other symptoms are managed. So we're looking into that and to collect the data to see what might be the best way to manage these patients. So going back to Canadian guideline that we talked about. So as I briefly mentioned, Canadian guideline that was published in 2019 suggests for the first time that palliative care should be introduced and discussed with the patient and at any stage of the Parkinson's disease. That is also the goal of that is to address, talk about diagnosis and prognosis, but also address symptoms early on. And then also their needs, psychosocial needs, or even clinically distressing symptom, the needs for managing those things, and then even the existential concerns that would affect the patient, not only the patients, but their families as well. If you could go next, please. I believe I just talked about that actually. Go to the next as well. Thank you. So it emphasizes multidisciplinary care and an advanced care planning and a shared decision making. And then for those who are interested, and there's a really good section. It's not a lot, 1 or 2 pages on palliative care for Parkinson's disease. And then I really hope that we will come up with a more comprehensive guidance and the recommendation in the next edition of the Canadian guideline as well. And then this would be a nice segue to caregiver. So whether Parkinson's disease is Parkinson's disease diagnosis is new, or the person that you're providing care has had Parkinson's disease for some time, the care partnership is really important in this patient and their family. And then it is crucial to make the care partnership as productive and as stress-free as possible as the care provider. So caregiver will likely encounter emotional, financial, and then physical because often they really carry these patients themselves at home, and even spiritual challenges along the way, for sure. So the preparing the caregiver and the family and the patient is a really important component of providing palliative care and then care for these patients. That's discussed in the many guidelines and in many publications or literature as well. And then we really hope to provide those tips and tools that will be really helpful for the caregivers so that they prepare and then manage challenges along the way. Parkinson's Canada, if you go to the next slide, please, provides an online resources for caregivers. This is actually a large booklet that talks about diagnosis, symptoms, medication, and progression of Parkinson's disease from caregiver perspective. And then they also talk about caregiver role and then what other circle of supports that might be needed along the disease trajectory. And they'll also talk about some of the resources. I always use this guideline or resources to the patients. And then also, they are also available to answer any questions about local resources as well. They do have a support line, and you could phone them, and then the patients can phone them or email to get those specific information, especially about the local Parkinson's society or information on the resources. And then, here is a phone number and then email address as well.
Okay, I know we've been talking for a while and everybody is probably very tired. We're going to just take maybe 5 more minutes before we take questions to tell you a little bit about the outpatient neuropalliative program here in Ottawa. I think everybody here is largely in the Champlain Linen, so this might be relevant for anybody that wants to know a little bit about what we do. And so I always kind of put this slide up to talk about kind of how we traditionally think about palliative care in general, where you have a diagnosis of something, really anything. Often you start with like disease modifying therapies, and palliative care kind of comes in this inverted wedge that as you get closer to end of life, you're doing less disease modifying therapy, more palliative care. And then you make that transition to what we typically call like hospice care, end of life care, really the final like hours, days, sometimes weeks of life after end of life. Then you have some the kind of bereavement period for caregivers and loved ones. Most palliative care referrals happen kind of around this phase, really as kind of disease modifying therapies are winding down and more end of life care is coming up. And when we talk about the community and how care is received in the community, often palliative care community referrals come around the same time. So patients usually have some functional decline. They're often bedbound, a PPS of around 40. They maybe have more symptoms and they maybe have more of a predictably short prognosis. And I think as we've talked through, and hopefully I don't have to convince you, that it's really hard to identify when our palliative care patients might be, or when our Parkinson's patients might be appropriate kind of in this spectrum because of the issues of kind of identifying issues with prognosis. And so we have started the Neuropalliative Care program, where we're seeing patients really at any spectrum of their illness to kind of manage this question that patients with neurological diseases tend to need a little bit more often earlier on in their illness. And, you know, there are some resources in the community already, like the Regional Palliative Consultation Team, and there's some excellent family doctors who are doing a lot of this care. We're considering as kind of another person kind of able to support earlier on in the disease course. So I'll tell you a little bit about who we are. So there's 5 physicians that work on our neuropalliative care team. Some of them you may know if you work with the Regional Palliative Consultation Team. So Dr. Kenna Brava, Dr. Kim and myself, as well as Dr. Jill Rice and Dr. Nick Tompkins. We're all palliative care trained, and Mujin is also dual trained in neurology. We have one clerk. His name is Kevin. He is incredible. If you have called us, you have spoken to Kevin. And we rely on kind of home care resources and Ontario Health at Home for allied health support. We are a largely home visit based program. We do have a footprint at the Ottawa Hospital. We can see patients at the Ottawa Hospital. So we chart in Epic and the Ottawa Hospital system, but we do a lot of our home based visits. So we go into long-term cares, we can go into group homes and retirement homes, we go to personal residences and those kinds of things. And the goal is to provide, you know, relatively early on specialist based neuropalliative care. We see patients at whatever frequency we feel like we need to. It's often patient dependent. We'll see people sometimes every month, sometimes, they're good and we'll see them every 3 months or so, but it tends to be a little bit earlier on in their illness. I always like this slide because who we are not. So we're not people, we don't get involved to manage exclusively chronic pain. There are some excellent home care service coordinators and the home care that is way more skilled at helping coordinate care for patients and caregivers than we are. And so we very much lean on them and appreciate them. With the exception of Woojin, we are not neurologists, so we do still engage with the patient's primary neurology teams to help us manage, in Parkinson's patients specifically, we might help them manage, deep brain stimulation, some more complex Parkinson's medications. We still really do engage with the neurologists. We're also not end-of-life care providers. So while all of us do provide some component of end-of-life care, the program is really kind of much earlier on to help with symptoms kind of earlier on in somebody's disease trajectory. And so we don't have a dedicated on-call service when our patients are approaching kind of that more end-of-life care prognosis, or we think that things are becoming more complicated where they're requiring a lot more on-call help. We transition them to some of the community teams a little bit more readily, where they can have more on-call access and those kinds of things. So we're kind of the before that. The program started back in 2022 when we started seeing just ALS patients. And this came out of some research that we were doing in ALS patients at the time. And I will say that we've grown rapidly since then. We've expanded to all diagnoses. So we see patients with ALS still, but we do have a big component of patients that have Parkinson's disease and Parkinson's related disorders as well. We've had hundreds of consults at this point, which is really exciting to see. And we have an active roster of somewhere around 60 to 80 patients at any given time. I won't go into the details here, but you can see that over time, this is Parkinson's and Parkinson's related disorders. Really, that's been our biggest mover and climber, where we see quite a lot of those. Now people are starting to recognize the need and where we're able to help there. And I'll skip that slide just for time. As Woojin kind of alluded to, we also do quite a lot of research related to our Parkinson's and Parkinson's related disorders and just neuropalliative care in general. So some of the things we're working on right now, we talked about the kind of non-oral options at end of life and rotigotine and what that kind of looks like. And Woojin is also leading a study looking at predictive models for Parkinson's prognosis using kind of some of that high level administrative data as well. This is how you get a hold of us. And so Dr. Tompkins is newly joined the team, so he's not on this card, so I have to apologize to him. But this is how you find us. This is how you can send a referral. You can send it through Epic if you're an Epic-based physician or an Epic-based team member. If not, you can fax us just a general consult here. We take patients with life-limiting neurological illnesses who have a palliative care concern. And so those concerns can be, but are not related and not limited to just difficult symptoms, unclear goals of care, or challenges with coping at home. But obviously, if you're sending us issues with a referral for challenges coping at home, we ask that obviously home care be involved. We don't have any restrictions on goals of care or functional status or prognosis. We're here to kind of assess our patients, and we just always say that we would sign off if we feel like we've kind of managed those needs and are no longer needed. And that's it. I'll stop talking about that program. We're here now to answer any questions that you might have.
There's Christine, you can look in the chat. There are two questions there if you want to address them.
Okay, I'll answer the first question about neuropalliative care, which says, do you cover only Ottawa? The answer is Ottawa-ish. You know, we're a 5-physician team, and there's one full-time physician working at any given time. Because we're doing home visits, we cover the entirety of Ottawa. And so we're driving kind of all over the place. So, you know, oh, I'm sorry, I'll go back to the last slide. So going too far out of the kind of general Ottawa area kind of limits our ability to see all of our patients. We do take patients kind of within about 30, 40-ish minutes, sometimes up to an hour in specific circumstances. But in those areas, often there's really good family physician coverage and RPCT coverage. And so we're happy to help support in ways where we might not be the we don't have any specific referral form at this point. And Wujin, I don't know if you're seeing them as well. There's one from Susan and one from like iPhone up there. I don't know if
Yes.
you want to take
Yeah.
a look at some of those.
The
Perhaps I
balance
can
between medication to cure and maintain and palliative care to reducing symptom, suffering, medical and spiritual and psychological.
Yeah. So we often talk about, even though this may not be conventional opinion, but because we don't have disease modifying therapy in Parkinson's disease, so we often talk about, since from the early stage of a Parkinson's, using levodopa or any other dopaminergic medication is really to manage the symptoms. So we focus on managing symptom, improving quality of life on these patients from the start. So that is really the pure focus of management of these patients, to reduce suffering, and then also provide really, really good quality of life with the expectations that a patient can have throughout the disease trajectory as well.
Yes.
And then there's a question about DBS therapy frightening or uncomfortable, and I wonder if you
Yeah.
can walk us through what this treatment process is. It is a surgical placement of the electrode into the deep area of the brain. And then we actually, at the Ottawa Hospital, we do have a 1 or 2 procedure per month. So it does require very extensive and then thorough planning and then execution. And then our Parkinson's movement disorder clinic works closely with the neurosurgery team to have this procedure done. And there are some criteria to qualify for this procedure. Of course, those are indicated or dedicated for patients in the late stage of Parkinson's, because after trying different medications. And then it is also for really severe motor fluctuation or dyskinesia due to the medications, or the symptoms, especially the tremor that is refractory to medications. So really to manage those symptoms. However, there's a clear and a very important criteria where the patient, so sort of similar to transplant of the surgery, the patient has to be cognitively intact. They have to have a good social support, because it is a large procedure and that requires a long recovery. And then the patient would have to live with the controller. They need to understand how to manage those things. So especially patients who are quite elderly and with some cognitive impairment would not be qualified for these treatments. Now there are new studies, research study, using subcutaneous infusion of a variant form of levodopa, and then that is actually being carried out at the Ottawa Hospital. And then those patients who would benefit from these trial medications, we would refer them to movement disorder clinic, and then they do have some criteria to qualify these patients for the process. But it's similar to our community CAT pump, the subcutaneous infusion pump the patients carry, but there are some other processes that related to that, but it is being studied at the moment, and then Ottawa being one of the sites.
Do you have any recommendations for nighttime bladder incontinence?
Very good question. I think, as Kristen alluded to, I think first thing is really to look into how we can modify or adjust the medication for motor symptom as well. So if the bladder incontinence is happening with other, the motor rigidity and then other distressing symptoms, really adjusting prolonged the extended release format of levodopa carbidopa can be tried and adjusted. Those are the usually first, I guess, the step of the management.
We sometimes use in patients, in male patients, like we will use condom catheters and those kinds of things. That can be helpful if it's tolerated and if it works, which not everybody does. That's another piece that we sometimes rely on in our male patients. I saw something in the chat says patient with advanced Parkinson's disease who sleeps a good part of the day. Yeah, that's really challenging. I guess my my first question with that is like, what does the night look like? Are they awake all night? Are they reversed in the day and night? And so
Mhm.
step one of that would be, you know, try to correct that with the non-pharmacological things, you know, sunlight, stimulation during the day, and those kinds of things to try to make sure night is night and day is day. Obviously recognizing that this patient with advanced Parkinson's disease probably will need to sleep during the day at some point. You can't expect them to be awake for the whole time. But really it's about optimizing kind of like sleep at night, sleep aids at night, optimizing levodopa if that's appropriate, treating any restless legs, managing the ferritin, all of those things. And then trying to manage the day as well. That's it, without knowing more.
Melanie is with us tonight from Niagara, and she's wondering if there are other neuropalliative teams in Ontario that you're
Great
aware of.
question.
Uh,
So
yeah,
yeah, go ahead, Bhujan.
Okay. I mean, from my understanding, there are a lot of movement disorder group or ALS group in academic centers such as Western University, McMaster University. They do have neuropalliative clinics to see these patients, either jointly with a palliative care team or they're within their neurology clinics. However, I do not know if there is a dedicated neuropalliative service that provides home visits.
Right.
As far as I am aware, we are the only home visiting team. I might be wrong.
Right.
So if I am wrong, let us know.
Yeah. And I got a question too about do you take self-referrals or do they need to come from a physician?
That's a good question. We've never had a self-referral. I think practically from just a purely billing perspective and like a systems process perspective, we need a physician referral.
Right. Mm-hmm.
But it could come from family physician.
Absolutely.
Mm-hmm.
Yeah,
It does not have to be a neurologist who refers.
absolutely.
Mm-hmm. Mm-hmm.
And in fact, we get a lot of referrals from other physicians than neurologists.
Right.
That's
Right. In your view, do you think that Parkinson's disease research has stalled or is advancing as a more rapid rate? Question. And how much hope do you think is justified for a cure for Parkinson's in the next 20 years? Question mark.
I hope that we do find disease-modifying therapy in the near future. And then to speak about the research, there has been tremendous advancement in the research in the last 5-10 years. And then all this understanding of a non-motor symptoms and then prodromal symptoms has come out within the last. So understanding these processes and then where and what part of the brain and how they're impacted, they are, I mean, should play as a foundation to finding disease-modifying therapy for sure. And then as we are looking into other conditions like multiple sclerosis, ALS, and other conditions, similar sort of advancement is happening right now. So I'm hopeful.
Someone's also asking a question about studies using nicotine for Parkinson's.
I am not quite familiar with that. We do have other disease entity that causes neurodegeneration that is actually related to smoking. It is more of the correlation than causation. However, yeah, I'm not quite familiar with the nicotine in Parkinson's disease.
Yeah, I remember briefly like a news story that came out years ago that was like smoking is neuroprotective. I don't remember the specifics of that. But
That's what
studies that I'm aware of that
there was a big study in
using
multiple sclerosis that smoking was found protective, but it is correlation, not causation.
Right. Yeah, that's what she's questioning. Yeah, that's great.
There's more questions I just see about sleep. And so the with sleeping all day and sleeping all night, that was sleeping all day. Yeah, as somebody with advanced Parkinson's disease, I guess the question would be is like, where are they in their disease trajectory? If they're sleeping all day and sleeping all night, that may be just an indication that disease prognosis is, you know, the disease is progressing. Obviously you would want to make sure that there's no like sedating medications or other medications that might be contributing, but it, you know, it is reasonable to see and expected that as somebody kind of progresses down that trajectory and is approaching kind of more of a like end stage Parkinson's disease, that they're certainly sleeping more during the day as well. Do you have any do you have there's a question about sleep hygiene, more on sleep hygiene. we talked a little bit about it, but is there anything else specific that you?
Yeah, sleep hygiene, I guess the discussion and the planning is all often very challenging. It's something that requires a lot of preparation and then I guess planning as well. But it is important. I mean, changing entire sleep habit is always difficult, but certain things that are possible. For example, having certain time that you wake up. So early morning waking up and also having a bright light in the morning, that has shown tremendous evidence that will help reset the circadian rhythm as well. And then, although we don't really understand how that might be different in Parkinson's, but that is the first thing I always recommend before getting into different sleep aids. And then also, as Christine alluded to, other reasons why they may not be able to sleep, restless leg, and all other REM sleep behavior disorder or other causes that usually are the first thing we address as well. But bright light in the morning, set time to wake up, that is a very, very important part.
Someone's asking at what point or do patients ask about MAID?
Yeah, it's a good question. I think it's very individual. I have had patients on my first consult with them be like, by the way, I'm going to have MAID soon. And that's their kind of declarative statement and decision. And then there are other patients that, never mention it. It's not within their goals. It's not something that they want to talk about. And then there are patients where, as we're kind of seeing them and as their disease is progressing and they're struggling more with symptoms, I often will kind of take a cue from the patient. Sometimes we'll say patients will say things like, I'm having a really hard time managing this. I don't know if I want to live with this. I don't know what the future will hold. It comes up often as a topic whenever you're discussing planning for the future. And so I think that's always my approach, is taking some cues from the patient, where they do definitely bring it up sometimes, but also taking it from kind of what they're saying to me as well as something that might be a priority for them.
There is a question, how much more likely would someone with depression or anxiety history be to develop Parkinson's?
It is as some of other non-motor symptoms, it's quite non-specific. They do have large, I guess a portion of a Parkinson's disease patients do have depression and anxiety develop before starting motor symptoms or early in their disease state. One specific thing that we see in patients with a Parkinson's, especially those with the atypical Parkinsonism, they do develop something called pseudo-bulbar affect as well. And those are some of the symptoms that are characterized in disease like ALS. So basically they are, I guess, a spectrum of symptoms where people have labile emotions. They are quite easy to laugh, easy to cry, or uncontrolled emotional output. So they do have that specifically in some of these neurodegenerative conditions, including Parkinson's disease.
People are asking about early testing of family history.
Yes. So the mean age of onset of Parkinson's disease is about 65 years old, but those patients develop some of the Parkinsonism much earlier. So in their 30s and 40s, and it is really important to look into genetic cause as well. And then also some of these other, if you remember on the slides, the primary Parkinson's with the atypical but hereditary cause, there are a list of many different hereditary cause of Parkinsonism. They do present with other symptoms, such as seizure or developmental delay, yes, and some of those symptoms. And then they do need to look into what may be responsible for genetic cause that leads to Parkinsonism as well. So early onset, always important to look at family history.
Yeah.
There's a question that says, I wonder if you have any advice on talking to someone about a recent diagnosis of Parkinson's disease. These can be difficult conversations.
Yes.
Yeah, I think they definitely can be. So I think with any diagnosis, or disclosing any diagnosis, having a conversation around Parkinson's disease or anything like that, I think in general, it's always important to understand what the patient and the family understand and what they want to know and what are the big things on their mind. To me, I think it's really important to have some of the knowledge around, what the prognosis might be, what some of the like early signs, later signs might look like, because people often just want information as to kind of like what to expect, what this might look like, what the prognosis might be. But I think it's always good to go in with like no agenda, the knowledge that you have that you can explain the disease and what to expect, but also just kind of really understand what their biggest issues might be. Some people might show up to this, their first question might be like, well, how am I going to be able to play golf? And somebody else's question might be like, well, can I care for my grandchildren? And somebody else's question might be something entirely different. So really listening more than speaking around these conversations, I find, is often the best way to go about it.
Absolutely. Early onset related to 22q11.2
Yeah,
deletion.
I think you speak about specific genetic mutation, I think on
Yeah.
chromosome 2. It is quite, I guess, a robust genetic mutation that cause hereditary Parkinsonism. I believe the onset of symptom could be as early as 30s and 40s. And then, yes, it is, I think, well-documented condition. And then not quite common. I haven't seen any patients with that, but yes, it is one of the genetic cause of a Parkinsonism.
Wow. And the last one, any idea how far research has gone in seeing how Lewy body can be addressed to prevent dementia?
I am not quite sure. We know that Lewy body, targeting Lewy body, has been, I think that's what you mean by that.
Yes.
So the misfolding into Lewy body can cause different disease entities, including Parkinson's disease. And then there has been a lot of experimental trials targeting this as well. I cannot speak of specific trials, but it has been quite of advancement looking into specific protein accumulation and especially Lewy body, and then also alpha-synuclein in Parkinson's disease. Yeah, for sure.
Lots of questions. I wonder about chronic pain in Parkinson's disease patients and how common is it?
Yeah, you heard in the video where the patient said like, oh, I went to my doctor first because I was having shoulder pain. So these patients definitely do have pain, a lot of pain related. Sometimes it's related to position, sometimes it's related to stiffness, sometimes it's related to like an injury that they sustained from a fall, which is super common. Definitely it's common. Yeah.
There are evidence that levodopa actually can improve pain and then fatigue as well and mood. However, it's not something that we see commonly, but we always try to adjust levodopa first to see if any of these symptoms can improve for sure. Rule number one, as we talked about at the presentation.
Well, Carl, people are saying they're really appreciating this session a lot. And people are thanking you for this session. Excellent presentation. Appreciating the time that you've taken to answer questions, which is really helpful for people who take the time to come to a session like this, for sure. Yeah, they appreciate your expertise and your willingness to chat with us.
Thanks.
Wish you could see all my patients, someone said. You're amazing. You're very informative. Yeah.
Okay, thanks everybody so much. It's always nice to come to such an engaged audience too. So we really appreciate that.
Thank you very much, everybody.